Hi, everyone. Welcome again to the Borderline Personality Disorder Consumer and Family Education Webinar Series. My name is Chris Palmer, and I'll be the moderator today. We are lucky to be joined by Dr. John Gunderson, who is going to be speaking with us on general psychiatric management, which is in some ways an old treatment, and in other ways one of the more newly validated treatments for borderline personality disorder. And you'll hear a lot more about it. For those of you who don't know Dr. Gunderson, he is a professor of psychiatry here at Harvard Medical School, and he really has been a pioneer and a leader in the field of borderline personality disorder, providing clinical services, but also doing research and studies, working with families. And he helped transform the diagnosis from what used to be a psychoanalytic construct into an empirically validated diagnostic category. Most recently, he's been focusing his efforts on increasing access to care. And that's what you're going to hear about today, this general psychiatric management, because it is a treatment for general mental health clinicians to be able to deliver competent, effective care to people suffering from borderline personality disorder. Before we get started, a few logistical announcements. All of your names and email addresses, phone numbers have been hidden from other participants because we do want to protect your confidentiality. However, we do want this to be as interactive as possible. You'll notice in the lower right-hand corner of your screen a Q&A box, and there you can type in questions or cases. If you've come to this webinar with specific questions in mind, you can even type them in now, and we'll put them in queue and get through as many of them as we can. In the lower left-hand corner of your screen, you'll see links to a lot of different websites. That first website is a link to our homepage where all of our webinars are archived. And if you haven't visited that webpage, please do, and look for other content that you might be interested in. The next link is in order to register for our next webinar, which will take place on February 5th. And then the next three links are just general resources of information and some referral sources for borderline personality disorder, so feel free to visit those. And finally, I want to just acknowledge that this whole webinar series has been made possible through a philanthropic gift from a family that's been affected by borderline personality disorder themselves. We would love to be able to continue these webinars, and there is a Support These Webinars tab in that field as well. And if you are in a position to help support these webinars, we would welcome any gifts, large or small, to help continue this series. And now I'm going to turn the webinar over to Dr. Gunderson.
Hello, everybody. I'm going to start this webinar by talking a bit about good psychiatric management and why it might be a partial answer, at least, to the public health problem that borderline personality disorder represents. The last estimate I read suggested that over 20%, indeed 28% of all psychiatric visits to outpatient clinics and hospitals were made by people with borderline personality disorder. Even if that is a high estimate, borderline patients have been a very prominent part of the clinical samples, the clinical populations that mental health services have been asked to provide for. Yet most psychiatric services do not have staff who are trained and even interested in being trained in how to treat people with this disorder. In years past, evidence-based treatments have changed the attitudes about borderline patients from being intractable and untreatable into a group of patients who can be treated successfully if given the treatment by people who have had extensive and specialized training. And that's been a major change and a major advance in the treatment of borderline patients. But it has not really addressed the public health issue because the number of clinicians who want to become specialists and undergo all the extensive and expensive training is not sufficient for the number of patients. Good psychiatric management, sometimes called general psychiatric management, is a treatment which was developed out of clinical experience. It did not come out of a theory. It came out of my and others' clinical experience in treating borderline patients. And so it has evolved over many years. I didn't actually think of it as a brand name treatment until it was used as a comparison treatment in the trial for this study that's now shown on in front of you. This is a multi-site Canadian study in which good psychiatric management or general psychiatric management was compared to DBT. They came out about even, and that was remarkable because it was assumed going into the study that DBT, especially high-quality DBT, which Marsha Linehan herself assured me was the case in this study, it was assumed it would do better than a less intensive, comparing once-a-week treatment with something that's closer to 4 weeks, plus meetings between the treaters. It was assumed the DBT would be much better. It was therefore shocking when the GPM module did just about as well in all outcome measures and was with about 1/4 the resource utilization, that is, the professional time required. It was at that point that I got on this mission that, man, this good sense, easier to learn form of treatment for borderline patients is something that should be disseminated and taught within the general training programs for all psychiatrists and psychologists, and even social workers, because it is more commonsensical. It doesn't require extensive training, and it doesn't have its own jargon connected with it. And if people could do well with this more modest treatment, we have then an entry-level treatment that all mental health professionals should learn, and which will be good enough for the majority of borderline patients. And only then does it get those patients who don't do well with this good psychiatric management, then they could get kicked up and go on to treatments like DBT or mentalization-based treatment or transference-focused psychotherapy. This slide simply summarizes the fact that the outcomes are very similar. Clinicians were not novices. The clinicians providing the GPM were people who volunteered to participate in this study. They had about 5 years experience. And the fact that they would volunteer to do this, they're interested in being treaters for borderline patients. So you can't generalize from that. Nonetheless, they were not specialists, and they had not had prior training in working with borderline patients. As I just mentioned, what we then have is a once-weekly treatment, which is good enough for most borderline patients and easy enough so that most treaters can learn to provide it, and that the DBT, MBT, TFP, the other more specialized, more intensive, and more expensive treatments would then be reserved for people who cannot respond well to GPM. So what's it like? It's once weekly, individual. And you note here it says, if useful. So we don't encourage clinicians to see borderline patients indefinitely, let alone see them more often if they're doing poorly. If the patient's responding and getting better, then you continue. If the patient's not, you raise the question, is there something wrong here? Now this approach to treatment is not based on the evidence-based treatments. This approach to treatment is based on what we know about the natural course of this disorder. It was shocking when, in the last 10 to 15 years, we learned that borderline patients aren't inherently a chronic condition. First, we learned they're treatable. Then we learned that even in the absence of specialized treatment, most borderline patients gradually get better. 40% remit by 2 years and 85% by 8-10 years. And once they remit, they stay remitted. So this means that if you're treating a borderline patient and they're not getting better, you actually may be standing in the way of the natural progress of this. But certainly you want to talk with your patient about the possibility that this treatment is not being helpful and consider whether something else might be more useful. It emphasizes diagnosis and psychoeducation. In this way, it is much more comfortable within the old medical model. You are a doctor. You don't have to be an MD, but you're a professional, and you're providing diagnosis about which there's a great deal of information and knowledge, and you're providing a patient, and as a participant in this, with psychoeducation about the nature of their disorder and about its course and its etiology. I'll come back to that and fill that in a little bit. Unlike psychotherapies, which generally focus on changing the person's psychology, this treatment is primarily, it's not like the other is unimportant, but it's primarily focused on the patient's life side out of the treatment, not on the relationship they're forming with you, the clinician, but on the relationships they have and the difficulties they have in their relationships out in the real world. Is that in that way very anti-regressive, and though we don't have evidence yet to show this, we believe that it has greater impact on improving the social adaptation of patients than psychotherapies have had. It's both psychodynamic in the sense that it deals with unrecognized motives and feelings, and behavioral because it emphasizes accountability, starting with the fact that if the patient isn't responding well, you don't continue in the treatment. Treatment is contingent upon being helpful or the patient's getting better. It's not that it's done only with the individual clinician and the patient. The clinicians are free and encouraged to implement other modalities as they see fit. Group therapies are the most cost-beneficial treatment for borderline patients. If you can get a borderline patient into a group, that's always a plus. Family interventions, the primary clinician, the person doing the GPM, they are free. They don't hire somebody else to do it. They bring the family right in, the spouse right into their office and deal with the patient directly with their significant others. And if the primary clinician is a psychiatrist, again, they don't farm out and differentiate. Somebody provides medications, the other person provides the psychotherapy. That's one task. Psychiatrist does it within the hour that they meet. So some of the things that are distinctive about this are inherent in my description. There's a big emphasis on diagnostic disclosure as an essential first step. The patient needs to be informed about and accept that this is a condition that fits them. It's case management rather than psychotherapy. Very heavy emphasis on psychoeducation, flexibly multimodal, and progress determines the duration and intensity. And then the last thing here, which I haven't mentioned, is it's governed by a theory, which is that the borderline patient's behavioral problems and emotional problems are secondary phenomena, secondary to the patient's reactions to interpersonal adversity. These are extremely sensitive people, and they can get extremely angry over something that looks minor. So you could say that they have excessive emotionality. That's true. But what that explanation overlooks is that that level of emotion makes sense if, for instance, if somebody you believe your love and your future depends on frowns at you, and that gets translated into they hate me and they're going to leave me, yeah, you're going to have an emotional explosion about that. Similar to the behavioral problems of borderline patients. They're triggered by, and this has been nicely demonstrated in empirical research, by adverse interpersonal events. These are some comments patients make about the disorder. I think it's important ways of thinking about it. Inherent in this is the idea that the diagnosis itself is an important event. And though GPM initiated the idea that treatments for people with this disorder should begin with an explicit diagnosis, discussion of it, and psychoeducation about it, it's with some satisfaction I can say that now the other treatment modalities have pretty much integrated this and are doing the same thing. In the process, they're casting a new look at this disorder, which is that it is something that other people have, that it can explain a great deal about their past history, including the fact that the previous treatments that these patients have very often received, why they didn't work. It gives a reasonable idea about what they can expect from medication, and it gives a hopeful idea that they can and should expect to improve. The other side of that is if they're not improving, you have to worry about the treatment. This is just information about the genetic disposition that just was not known until 2000. All the conjectures, all the many, many papers written about how people become borderline had to do with environmental causes. It wasn't until 2000 the first major twin study was done. It was discovered that at that time, I think it was 58% estimated heritability. This is 55% here. That's more than depression, less than schizophrenia. I just completed a review for a prominent scientific journal in which the geneticist who co-authored this with me raised the estimate of the heritability to 70%. I'm still wrestling with that. The important thing is, for people with this disorder or people treating this disorder, is you can and you must really enter the field of treatment with an understanding that this is not simply caused by bad environment, that these people have some hard wiring and some inherent handicaps which they can overcome, but with difficulty, and that the idea that they will have a fully satisfactory cure is not likely. They can make satisfactory adaptations to this genetic disposition, and many of them go on to have such a satisfactory adaptation, including stable work. But it is not. It's something they have to overcome. It's not easy. The different elements of the syndrome, emotional and behavioral, interpersonal, and cognitive, are all united by an underlying core. This is important because it means that there is some kind of unifying force behind the different and quite disparate features of the phenomenology. We don't know what that is. And in that regard, we're not much different from other major psychiatric disorders where they know that there's heavy heritability, but they have a real hard time saying what it is that's inherited. We'll scroll. This slide summarizes the course, which I said was much better than we imagined. Well, it is much better than we imagined. The blue line says the percentage of patients who are remitted. The red line shows the decline in the number of criteria over time. Now, that's not for all patients. Within that, there are patients who will go down to 0 criteria, and there are some who are still going to have 7, 8, 9 criteria after 10 years. So by no means is any individual patient assured that this will be their fate, but it does mean that a good treatment should see progress, and if a patient's in treatment and they're not making progress, there's good reason to worry that the treatment isn't helpful. I'll be glad to meet with you weekly. This is what the good GPM doctor says. He said, I'll be glad to meet with you weekly, but I'm reluctant to meet more often until we see whether I can be useful. And then it goes on to enlist the patient in looking at the symptoms and whether they're changing or improving. The 6 basic principles of good psychiatric management, I'm not going to go through them each. They're sort of self-explanatory or redundant with things I've already said. I would want to say a little bit more about number 4. Many borderline patients are preoccupied with their relationships. They have grown up with the idea that their needs have been unmet, and that as they approach adolescence and early adult life, that the solution for them is going to find a partner who is going to be fully committed and to them. And they are more than willing to commit themselves wholeheartedly to somebody else with that unconscious promise in mind that the person will reciprocate. Well, nobody who's got much of a life wants to devote all of their time and energy to one relationship. Sorry if there's romantic people in the audience who think that. But anyway, it doesn't work. So in the GPM, we tell patients this, it's understandable why you might hope for that, but it's unrealistic. If you want a stable partner, which most all of them will want, then you first have to learn to take care of yourself. A partner wants to come home to somebody who can take care of themselves. They're not going to want to come home to somebody who's going to be angry or jealous about what they're doing with their time away, and who's going to have a possessiveness to their devotion, which is suffocating. That's not a way that you can sustain a good partnership. So we're very explicit with patients that this fantasy, this dream of theirs, is just not realistic. In contrast, we say, you should devote your energies and whatever talents you have to finding some role in the world where your self-esteem can be buttressed, where when you have a relationship, your self-esteem isn't going to rise or fall with the frown or the smile of your partner. So we want patients to go to work or back to school or to school. And increasingly, we insist upon it, that the treatment isn't going to be very effective unless they're involved in some responsible role in the community, and that we can help them overcome the obstacles that they face in doing that. In the background, it isn't that they should love work, but they may learn to get satisfaction out of it, but that if they can work responsibly and function in the community, they become a better candidate for a love relationship. So, what else do we have to say here? This is my last slide, I guess, and then we'll get to question and answers. Borderline patients should be able to assume that professionals who treat them have been trained to do so. I would modify that as I immerse myself more in this public health campaign, that all mental health professionals should have been trained to provide adequate care for patients who are going to occupy a good number of their hours wherever they go in their professions. All right, so you tell me what's on your mind. I hope this has been helpful.
Thank you very much, Dr. Gunderson. So again, I want to remind people, if you do have questions, go ahead and type them into the Q&A box, and we'll get to as many of them as we can. We do have a question already. So our son, who has borderline personality disorder, has a pattern of looking for love in all the wrong places and seems to attach to people with similar issues. This has created many problems for us in welcoming or including his choices. My son says that no quote-unquote normal woman would ever be interested in him. Any suggestions?
Well, he's probably right. If he's going to pursue a romance with such ardor and passion and his future depends on it, he's not likely to be a good partner for somebody. Help him get a life where he has some source of satisfaction and self-esteem that would make him a better partner for a woman.
And how do you, let me push you on that, because so a lot of our viewers and participants are family members, and they love the way that sounds, and I know just from years of experience, they have tried innumerable times to do exactly that, and they get a lot of argument, or they get shut down and depression, or they even get self-injury and a suicide attempt after they say something like, well, if you had a life, if you had a job, maybe you'd be a better partner, and then they go up to their room and cut themselves, and then that, for a lot of parents, feels like, well, that topic's off the table, I can't go there. And so what's the parent to do?
First of all, I'm not confident that many parents give the message that I just gave with much confidence. They may say that you shouldn't get so involved with this person, and yes, it's a good idea to get you to get a job. But I don't know that many parents put the two together in this way, that if you want to have a good partner, a job is a major step on the way, and that if for no other reason than your wish to have a stable and loving partner, you need to be able to take care of yourself, and you need to have a self-esteem that isn't going to rise and fall with that relationship. That, see, is a commonsensical message, which is yes, the borderline son or daughter may not like it. They may storm out of the room or da-da-da, but there's such an undeniable truth in it. Borderline patients will be able to tell you, I'm failing in my relationships. That's one of the major reasons they seek treatment is, I keep getting rejected. Well, this is one way to address the reasons why they're getting rejected. The idea that they need to change their psychology first and then they'll become a good partner, I think isn't the case. Those psychotherapies which have been conducted, which have been very impressive in their efficacy, have really helped borderline patients lose their symptoms. They have not been effective in giving them satisfactory lives. So that dramatic decrease in the psychopathology, the dramatic rise in the number of remissions, with the treatments which have existed, has not been accompanied by satisfactory interpersonal and vocational lives. None of those treatments has ever addressed that as a major goal of the treatment. Now, I can't claim that GPM can say with confidence that we do it better, but I do know that we are addressing the issue and that it is very hard for borderline patients when presented with this way. You need to get a job because you want to have a partner. That's a little bit different than you need to get a job so I don't have to pay for your bills. You're linking the vocational world to their longings for a stable partnership, which is almost universal in people with borderline personality disorder.
Okay. So, and if I can maybe just remind for viewers maybe who are new to the webinar series, so part of what you're describing is validation as an entry point. In terms of just validating you really want to have a partner, and that's a reasonable thing. That's a desirable thing. I can really understand that.
You're capable, and you're
of
capable
course you want a partner, and that's a wonderful goal, and that's a wonderful thing, but maybe you're going about it in the wrong way.
I interrupted you and I said it wrong. I mean, what you want to say is you can become capable of it. That the way you're going about it is just going to handicap you. The intensity of your wishes, the needs that you have from the other person, are going to trigger the rejections you fear. You have to have your feet on the ground and be able to take care of yourself to be an appealing partner for somebody.
We've had a few people ask about general or good psychiatric management. So one person asked, can this treatment be used with comorbid conditions? Because we know comorbidity is a common challenge in borderline personality disorder.
Well, that's a complicated question. For what it's worth, in the comparison with DBT, those patients who had more comorbidities did better in the GPM than they did in the DBT. And that's partly because the GPM is a more medicalized approach to borderline patients. And it is more apt to effectively address or at least provide education about comorbid conditions. What gets more complicated is that a lot depends on what the comorbid condition is. Typically, borderline patients present with depression. 70% of them will have had lifetime major depressive episodes. It is very common and understandable up to a point that clinicians will then latch onto the depressed diagnosis and want to treat that, typically with antidepressants. Ironically, the depressions that borderline patients have are not responsive to antidepressants. And so what it starts with this cycle is that they will begin to get chronic depression and feel like they're less treatable, and so hopelessness becomes part of the picture. It is much better if depression and borderline co-occur to say, if we can help you with your borderline, then the depression is likely to remit. You can take medications for the depression, but don't expect much from them. That's a much more viable and empirically based approach to that form of comorbidity. Similarly with anxiety disorders, the anxiety disorders will usually go away if you treat the borderline. Now, post-traumatic stress disorder, there's a development now of treating them concurrently. And that's a very good approach, but you want some people with expertise to do that. I think I'm digressing a little bit from the issue. Bipolar disorder, I just stop to mention one last comorbid condition. Again, many people with borderline personality disorder are or have been diagnosed with bipolar disorder. When that happens, it conveys to the patient and their families that the patient is likely to recover due to the benefits of mood-stabilizing medications. When these disorders co-occur, you can, and the person is truly manic, you can treat, and you need to treat, the manic episode with mood stabilizing. But it is not going to affect the borderline personality disorder. And you cannot treat borderline personality disorder as a secondary disorder. It also requires treatment. If you treat the borderline personality disorder successfully, that also is not going to greatly affect the bipolar disorder. They're independent disorders, and that is really, this has been established. They don't run together in families. They don't affect each other's course, and the brain neurobiology is very differentiable. They're quite different portraits of what goes on in the brains of people with bipolar. It's so interesting because both of these groups of patients are emotional and impulsive. You'd think they'd be first cousins. They're not.
On the topic of comorbidity, since we're on it right now, somebody else asked specifically about comorbidity with substance use disorders and whether
That's a good one.
Whether GPM, good psychiatric management, can be a treatment for that, or how do you think about approaching people who have comorbidity? And we just heard in a webinar last week that about 50% of patients with borderline personality disorder have or have had a substance use disorder at some point.
Yeah, that estimate sounds right. If a person has a severe substance abuse disorder, you're not likely to be able to treat their borderline personality disorder. It takes priority. They have to be sober and committed to it in order to withstand the kind of challenges required to take control of your own life. And what good treatments, including GPM, have in common is they say to people with this disorder that you need to be able to learn how to take charge of your life. That's a message with somebody who is devoted to and preoccupied with getting their next substance. They can't manage it. If, on the other hand, you have somebody who is sober or has an intermittent, not too serious substance abuse problem, then the treatment of the borderline personality disorder can proceed. Under those circumstances where somebody gets wildly drunk intermittently, you can treat the borderline personality disorder, uncover and why the person has those binges, and learn skills for coping with it, including insights into what is usually the interpersonal adversity that precipitates somebody into drinking too much.
Okay. So I want to stay on this topic because several other people have asked about just good psychiatric management and where can we find it and when is it coming to a local theater near us? And so one person asked, is the treatment available in Canada, and if so, where? But I want to broaden the question because this in some ways is a formal treatment program, but in many ways are general principles about how clinicians can work effectively with people who have borderline personality disorder. And a lot of people don't put up a certificate saying, I am a good psychiatric management practitioner, or I've been certified by John Gunderson to be a GPM treater. And so given that people won't advertise them, whereas with some of the specialized treatments like DBT in particular, that's in the title of the program, or it's in one of the headings of a clinician's kind of skill sets, is that I am a DBT trained clinician. And so how do people go about finding a clinician who's either been trained in GPM or knows enough of the skill sets of GPM to be a competent provider?
That's, again, a complicated question to answer. It's true. We would not want people who have learned to do GPM to advertise themselves as GPM practitioners. We would want them to advertise themselves as good clinicians who have had training in the treatment of borderline personality disorder. Because most of this is not like specialist stuff. It is stuff that every clinician can and should provide. Our approach to disseminating this has been less to have workshops for clinicians where we do that, but clinicians who will then get trained and then we will supervise them and so forth. We have done workshops for clinicians which show that attitudes change, but a more fundamental approach to this has been to infiltrate the training programs. And over the last 3 years, we have done 5 workshops, 2 or at one point 3 days, with people who are responsible training directors in psychiatric residency programs. So we've had, I think, around 75 to 80 training directors that we have taught both what this approach is and how to teach it. I wish I could say that all those 80 training directors went back to their programs and immediately transformed the curriculum in their schools, but I think that sometimes that's happened, and almost uniformly it has generated much more enthusiasm and competence about how to teach residents. It starts with changing attitudes. Many, many clinicians have grown up with the idea that these patients aren't treatable. Or if you have to have such a patient, then you should refer them to an expert. So getting this attitude change is the broadest and widest way to approach the public health issue. We've, I think it was, I can't remember, maybe 1,500, 2,000 people, clinicians who've attended our workshops. There's a lot of interest in it. We now have 9 official GPM trainers, that is, people who can go out and do the same workshops that I do and have skill both in GPM and skill as teachers. And we hope to continue to expand that number of people. With respect to Canada, Canada has a better healthcare system for implementing standardized care, and some of our best teachers and some of our best sites for good psychiatric management are in Canada. Indeed, the multi-site study which first established general psychiatric management as being effective was a Canadian study.
Good. The next question is, could you talk about what is known, if anything, about the co-occurrence of being in a sexual identity minority, so homosexuality, in the context of borderline personality disorder? Is there anything known about that group of people, and are they at higher risk of committing suicide? And we know that both factors independently are a risk factor for suicide attempts and suicide completion. And so do we know anything about people who are both homosexual and have borderline personality disorder?
I'm a little bit embarrassed to say I don't know very much about that. I don't even have a very strong impression about it. I would think that anybody with issues of their identity or who feels that their identity is something that alienates them from other people are more apt to have borderline personality and vice versa. So what's the chicken, what's the egg there? It's just an interesting sociological issue. And yes, I would imagine, but I don't know, that the co-occurrence of somebody with sexual identity conflicts and or questions and borderline personality disorder, that they're probably a higher risk of suicide, but I don't know that. So it's an interesting subject.
Yeah, no, I agree. I haven't seen any data on that at all, but it has come up a lot, and I am aware, and maybe you can speak to this, you would know better than I, but I have at least heard some speakers mention that among people with borderline personality disorder, diagnosed with borderline personality disorder, there is a higher likelihood of being in a sexual orientation minority, being gay or lesbian.
I would guess that, but I just haven't, I don't know that.
And again, I think you'd have to do like a really large population study to give a definitive answer on that, because otherwise you've got a lot of selection bias.
You do.
And, are gay and lesbian people less likely to seek psychiatric care, for instance, maybe because they don't feel that they will be accepted in a medical community, or...
In general, I mean, they're more apt to feel unaccepted and to be the subjects of ostracism in one form or another. So it's a natural part of the population where you would expect them to be more likely to seek help and to have more questions about their identity.
Yeah. And one other unifying theme between or I don't even want to say unifying because that implies that they're related, but a common theme for both populations, gay and lesbian bisexual and certainly transgender people. And for people with BPD is self-hatred. Or at least concern about, will I be accepted, am I lovable? And I know Jill Hooley, Dr. Hooley, has done some research showing that alone, self-hatred, is one of the best predictors of self-injury.
Yes, and it's one of the core issues for people with borderline personality disorder. I mean, that long before any treatments were developed, that was one of the early and, from my point of view, one of the core building blocks for my development of expertise in this area was the appreciation of the self-image of toxicity or being evil, or certainly being unwanted, which is so central to most of the people with this disorder.
Yeah, and I already want to put out the disclaimer for everybody listening that I meant no bias in my question. I certainly didn't mean to imply that people who are gay or lesbian should hate themselves, but because of society's homophobia and a lot of cultural values, they are at much higher risk of coming to the place of not liking themselves or feeling insecure about themselves. So I just want to put that out there for the people who I know will criticize me for what I said or the way I framed my question. The next question is a complicated one, but I think these complicated ones can be informative. So this is a case. Somebody wants to ask you about their daughter. So our 31-year-old daughter, we believe, obviously has borderline personality disorder, but has been diagnosed with a variety of other things: depressive disorder, substance abuse, bipolar disorder, post-traumatic stress disorder from sexual abuse, both in childhood and at the hands of a stranger and during college. Her primary support is her therapist, who will be retiring soon. We, as a family, are only allowed to talk to the therapist maybe once a year, if we're lucky. This questioner says, my mother had an undiagnosed mood disorder, but they don't seem to have questioned any kind of genetic predisposition. Our daughter does not work, and the therapist supports this, saying that she's not ready for employment. We are totally financially supporting her, but of course every now and then we get accused of not being there for her. The good news is that after 4 years of twice weekly psychotherapy, she's now started in a group, but she herself has given up on expecting a love relationship, refuses family therapy, seems like when pressured under any circumstances, brings up manic, kind of says, I must be manic, or brings up symptoms of post-traumatic stress disorder. And in the family's perception, they feel like that's an excuse for not moving ahead with her life. And I know, again, highly sensitive topic where certainly people can have symptoms and can be vulnerable and can be in a position of not being able to move forward, or can at least have symptoms that seem pretty overwhelming. What if any, kind of thoughts or advice might you have for a family who is in this position?
Well,
it's not uncommon.
Sadly, this is a story that I've heard many times, and there's no single cause for your daughter's life having evolved the way it is. There are clearly some structural issues in the treatment setup which are fundamentally wrong. That is, if the parents are paying for the treatment, then they should have at least access to progress reports on its work. And should the therapist has some accountability to whoever is paying the bills. Now, when you have a daughter who's after the age of 21 and refuses that, the therapist may feel handicapped, or if they haven't already sort of bought into this, that you're the cause of the problems, and therefore she wants to protect her patient from you, the parents, the therapist may refuse such relationship, but such contact and such information. But when you have a daughter who's not getting well with this diagnosis, then you got to blow the whistle. This is a treatment that isn't working. Now, maybe if your daughter was seen the best treater in the world, she'd still be a chronically handicapped person. Can't say that. What I can say is that this is the kind of course that I've observed many, many times in the first 20, 30 years of my career, in which was used as evidence about how intractable or untreatable the patients were. In retrospect, what we know was that the treatments weren't any good. In fact, oftentimes the treatments had within them things which were actually harmful to these patients. I digress, but one of the sorry truths about people with borderline personality disorder is that they may ask for and get treatments that are bad for them, and then cling to them, and that the parents, under certain circumstances, need to take the very highly unpopular stance of saying this isn't working and getting an outside consultation. Clinicians have a hard time refusing to get consultations. And that would be the obvious place, if I were you, that I would start and insist on it. I don't know what else to say, whether the manic episodes or the PTSD symptoms, if those arise when your daughter feels threatened, that's, I think you can understand the defensive response to feeling threatened. And they are both symptom profiles which usually beget sympathy. Oh, she's sick, so she should not be asked to do something she doesn't want to do. And but they're not constructive. That is, your daughter's not going to move any place. She's going to become, or already is, I guess I would say, a very chronic patient.
So can I push you a little bit on pragmatically, how do you envision the conversation going? So if you're a parent, you're not a clinician, you're a parent, and you find yourself in this position, and your daughter's been in treatment for over 4 years, is highly attached to a therapist that she's been seeing twice a week, gets angry when you even talk about the therapist. She wants to protect the therapist from you. She doesn't want you contaminating that relationship. She might allow you to speak once a year because she's very defensive. She feels like this is the only person who understands me. This person understands why I can't work. This person understands why I need to be supported financially. This person understands all of that and supports me. And I imagine in the daughter's mind feels like that therapist is the only person who really cares about me. And I agree with you. I've seen that all too many times myself, and that's why I'm trying to dive deeper and get at least your recommendation. So if you're a parent, it's an enormous challenge and obstacle. And I'm worried that just going in and saying, would you consider a consultation? If you ask it as a question, it's going to be a no. And then if you say, we're going to get a consultation, let's get a consultation. Fuck you. How dare you? That's the only person in the world who supports me. That's my lifeline. I'd probably be dead without the therapist.
I would start the discussion with the fact that the patient has not progressed, and that it is not inherent in her diagnosis. That is, the majority, the vast majority, you could even say, of patients with this disorder improve and improve significantly over this period of time, even in the absence of treatment. So when you're into a treatment which is this intensive, I think it was twice a week, and this intensive and this expensive, and the patient's life is not changed, there's a need for consultation. You come in, there's nothing controversial in your statements. That is, you have a disorder which should improve. Sometimes it doesn't, but most of the time it does, and we and your therapist should have reason to expect that. If it's not happening, let's look at it. Let somebody else come in. Maybe there's things that could be done. I would hope your therapist would hope so. I don't know how your therapist feels about this, but if your therapist is well informed, they will certainly be aware the majority of patients with this disorder get better. And if it's 4 years, I thought it was even longer, but if it's 4 years into a treatment without much improvement, you should see discrete signs of change in the first 6 months. This is a long time. And I assume your therapist would welcome a consultation. Or she wouldn't. Oh, I don't understand that. Does she think that this is the best that you can do, that this is, that she doesn't have any expectations that you'll ever have a life where you have some independence and some interpersonal or vocational sources of satisfaction? Why would she think that? I mean, that's another question for a consultant. Maybe she's right. But we've been, and if they have, certainly it would help arm them, but we've read a lot about this. We sought consultation. We were on a webinar where we asked this question. And this expert said, oh my goodness, that's terrible. You need to get a consult, and maybe this is as good as it can be, but it sure goes contrary to the natural course of the disorder. And it's toxic if a therapist is given up.
Yeah. Okay. So I think we've got time for just one more question, and I'll end on given that this is a mission of yours in your career, increasing access for care for people suffering from borderline personality disorder. From a public health perspective, are there any advocacy steps that can be taken to raise awareness about training mental health professionals on effective treatment for BPD? What can people do to improve the situation?
Well, I'll bet you might have some better answers than I. Certainly, joining national mental health advocacy groups. The National Alliance for Mentally Ill has adopted borderline personality disorder as one of its causes. There's the, in this region, the New England Personality Disorder Association. On a national level, there's the, Perry Hoffman's organization, the National
Educational Alliance for Borderline Personality Disorder.
NEPD. So that is one way that you can certainly help. And being more aware and being less self-conscious and apologetic about talking about the diagnosis. It's a major medical illness, which the chances are everybody you talk with will know or have a relative with this disorder. It needn't be hidden or surrounded by the shame and the stigma that has typically been associated with this. It's major psychiatric illness where informed people, psychoeducation about this disorder has already been shown in numerous trials to have an important impact on the prognosis of the disorder. Just having patients get a good education and their families changes things. One of the curses of stigma surrounding this is that clinicians don't talk to their patients about the diagnosis even when they know it's there. And it sets in motion very unrealistic expectations about what medications are going to do, or a shorter term remission course. And it's a gradual one, but it can be enduring. But patients and their families have to be oriented around this.
No, I agree. And I mean, so one other just a comment from somebody from Ontario shared that he's going to talk with his primary care clinician and have that person watch this webinar. And so I agree with you. I think shame and stigma have really are major factors in accessing care, and are major factors in insurance reimbursement.
And in getting the mental health professionals trained and up to speed.
Yeah. So I think with that, we're going to have to conclude this webinar. So thank you very much, Dr. Gunderson.
Thank you. A pleasure.
And I just want to remind people, if you want to register for our next webinar, February 5th, you see the registration information on your screen.